Okay, then I'm okay.
Okay. Yes, Doctor.
So thank you so much, Madam Chair. The issue of private wing allowances not paid, I think that was one of the activities affected by the underfunding, the budget shortfall. Now, when we budget and the funds are not released to us, some activities get affected. Unfortunately, that was one of them. It was not that we had the money, but we refused to pay. But for the issue of the variations in the salary, I think the PHR, or you can say something about that.
Before,
asking
before
for the
you leave
lowest
that
pay.
point,
Yes.
somebody goes to the private, they pay their money to receive a quality service. Are you aware that if you don't pay allowances to somebody, that automatically can lead to a compromise into the services rendered? Because somebody comes to private to get super services. Then you have medical workers who are not paid their allowances. So if you demotivate them, automatically I will feel, I mean, I will suffer the consequences. So as we look at some of the things, we are looking at, we are considering this the same challenge in universities. We parents pay money, you know, and somebody tells you there is understaffing. You compromise the quality of education, but when we've exorbitantly paid, how do I gain from this? So you must make sure that this doesn't happen in the private. Even we don't encourage it in the general, but in the private, this makes matters worse. I'm telling you, allowances for the private where people pay their own money. You must see how to curb this. You must negotiate for this.
Madam Chair, I don't know whether you took time and looked at that table 5, the number of activities that were affected, because there are a number of them that are very pertinent. For example, when you see a door of the labor suits, like some of the doors were not repaired just because of underfunding of 2.5 million out of the 25 billion that they receive. It is very unfair, Madam Chair, when you see a regional referral hospital failing to at least work on a labor suit, because those are some of the activities or services that people will come for from the referring facilities around.
So the fact that these were underfunded, they didn't receive the money, we just skipped it, because you qualify these to be unfunded priorities. You would like to have them executed, but your hands are tied.
They choose what not to fund and what to fund, Madam Chair. That is the concern, because the main reason as to why a woman is referred from a facility to this regional referral, at least advanced giving birth is one of those.
Advanced services. One would think when you go to Jinja regional referral, even if your husband is too dark, chances of producing a brownie child are so high, because because the environment is so super. So, Doctor, take note. We know we appreciate the challenges of underfunding, but Honorable Grania, if you also picked interest into what they funded, you might find that, aware that the capital development budget and maintenance budget is limited. I think it's up to us to ensure that they are given reasonable, adequate funds to have some of these activities. Because at the end of the day, everything is important. Everything is a priority. But, you fall short of what to leave out. Otherwise, if we had an option of what do you have in Busoga, you have sugar cane. The price of sugar cane really. So, and you can't do much. How many baskets of umboli do you have to sell to buy? If it was the other side of the cows where Mujisha comes from, you sell 2 cows and solve a problem. So,
before you go for the cows, some of these unfunded priorities, you also see some you cannot justify. For example, if you say construction of hand washing facility at the gate, 60 million. What type of hand washing facility would that be? Emptying OPD toilet, 5.5. Some of these you see are exaggerated. Hand washing machine of 6.4 million. It's a hand washing machine.
Chair, Chair, this was a hand washing facility. It is a hand washing facility, which actually is worth that cost indeed, because if you, it has several hand washing points. It has a concrete basement and different taps. So, in my opinion, it is worth the 6 million. And if you look at these activities, actually, these activities will be prioritized. But in that quarter, the fourth quarter, I think, when these funds, the funds were sent but later recalled, I think the senior accountant can explain that scenario. That's how we ended up not implementing these activities.
How did your, Madam Chair, how did the hospital miss having such during COVID? Because all these things were put in place during COVID time
Repair.
and after. Yeah.
Wasn't it this repair?
No,
construction.
Yeah, this is a construction. What we had during COVID were mainly these mobile hand washing facilities, but this is a permanent construction at the entrance of the hospital, so that everyone coming in can first wash their hands before they access our facilities.
Okay. Honorable colleagues, will proceed to timeliness of implementation of projects, that is delivery of services from implemented activities. Tell us about this project of construction of a fence and motorized boreholes. What led to the delay?
Thank you, Madam Chair. Madam
Chair, you missed one out. This one of emptying toilets. Now that they were not emptied, what's happening?
Subsequently, we have emptied them because in the quarter following that, when we got some resources, we have been able to empty them. Then use.
I was worried.
No. So, Madam Chair, if you permit, I can say something about this, the delay of the project for fencing.
I'm sorry to take you back. If a hospital is challenged as having unfunded priority for emptying toilets, sincerely, that raises some questions. Doctor, we should not have that appearing under unfunded priorities. Because, you see, the record about Ginger Hospital, in that very office where you are seated, one time the fountain visited and was happy with one director, and he appointed her an ex-official minister for health because of the cleanness of the hospital. But Madam Chair, we need to be very strict on this. A hospital, you go there for healing. Then if the toilets are not emptied, how many flies do you entertain around there? Because those are questions, Doctor. They are not in a bad faith, but this should not be among unfunded priorities, because it deals with human life and the cleanliness of the hospital or anybody's home, including yours and mine and yours. How does it appear? If it would be even construction, I can't accept. Those are supposed to be first areas of attention in a hospital. As I will place another issue ahead. Actually, if she would allow, it would be even handled between here and we move on.
No, let's move chronologically. Please.
Madam Chair, that concern is noted. Although we had our plan Bs, or maybe at the appropriate time we can discuss that. But allow me to say something about
plan B. You know, when you come here and talk about plan B, some of our colleagues this side will ask, what is plan B? Grania will ask you, plan B, eh? Plan B is equivalent to Kavanje, so.
Madam Chair, I can talk about the plan B we had during the Ebola outbreak. You remember, we had cases of 3 cases of Ebola from Busoga, and so our partners supported us with some mobile toilets that we were able to employ. And of course, when a facility is full, we lock it. We cannot allow it to be used, so we had to use others until subsequently we were able to put right what needed to be done. Thank you, Madam Chair.
The consequences of having such, because I know you don't have that big space. So we should avoid that. Yeah, that is not something that can be underfunded really, or unfunded, an unfunded priority. NEDA. That is pure unacceptable. So let's proceed.
Thank you, Madam Chair. On the issue of the delayed implementation, or completion of the projects. We had the fencing of the hospital, partial fencing of the hospital, and also a motorization project which were batched together and implemented by UPDF Engineers Brigade. But once we contracted UPDF and they started the work, we had some issue of conflict, land conflict, with the Uganda Muslim Supreme Council, which some of you could have heard in the media. But eventually, we were able to conclude on that matter. Of course, it delayed our implementation because at some point, the contractor had to halt to allow us time to sort this out. But a good thing, Madam Chair, we were able to engage that issue, and eventually this project was completed and has been handed over.
A title.
Supreme Council, that it had been given to them as an access, and therefore they also wanted now to take the 4 acres of land. And based on a pronouncement, I think, which was made by President Idi Amin, but this matter went to court in 2009, and eventually the High Court in Jinja gave a ruling in favor of Uganda Land Commission, of course, Jinja Regional Referral Hospital. However, because we had this judgment at heart, we went ahead, following guidance from our permanent secretary that we need to secure these public lands, lands for public institutions. We decided that we should now fence it off. And when we contracted UPDF and they started, then that's when our friends rose in arms and you know, they blocked us from proceeding. And therefore we had to engage other stakeholders to address this problem.
So is it now sorted?
It is now sorted, and that fencing was completed. These projects have been handed over to us.
Yes, Honorable.
You see, can we get it correctly? And the doctor, you have said it twice. Is it you who contracted UPDF? Because we want to know, did your hospital contract UPDF by you, Jinja Regional Referral? Just say yes or no. No, don't help him, please. We are getting what to write, and could you tell us that?
Madam Chair, my senior procurement officer is here. He can guide.
Yeah, we need to hear.
We have guidance that the projects...
No, the question,
yes,
through the chair, is you have said it twice.
Yes.
When you contracted.
Yes.
Meaning the contract was between you, Jinja Referral Hospital,
yes,
and UPDF Construction Brigade.
Yes.
Can you put it on record that you did contract UPDF?
Madam Chair, I can say yes.
Okay. Now that's what I wanted. There is no problem with it. Because what we had from MASAKA, they were eyes on, hands off. For them, they are not involved at all. But Jinja, for them, they contracted UPDF by themselves. Not through a directive, but very good. We note that, Madam Chair.
Could be, we also look at the nature of the project. The oxygen plant, the other one was an oxygen plant that was centrally handled by the ministry. Now these ones have a fence, but UPDF has also gone too deep in these things.
Madam Chair, maybe before Elijah, just 1 minute.
It will help you.
Okay.
Chair, I think unless doctor is contradicting what the Auditor General has written, because if you go to page 36 of the Auditor General's report, because they are raising issues regarding that procurement, because they said there were challenges because there was absence of memorandum of understanding between the hospital and the contractor to guide on the responsibilities of each party concerning payments, implementation, supervision, and grievance resolution. 2, failure to identify the initial total cost of the projects and project milestones due to the absence of a jointly agreed and approved bills of quantities. It names them up to E. So you mean you have a contract with them and you don't have this?
You see, why I'm insisting, and we as a committee, we are noting from our witnesses, he has given us very good information. And his information is even energized on page 37. I have come in late, but I've already read. When you go to page 37, Advanced UPDF, Indian Brigade, you note that it is the hospital itself which advanced 359 million, but we shall get there to UPDF. Meaning for them, they are contracting UPDF as an entity. But why I never wanted to take long on this matter, we are getting our conception as a committee that there are entities contracting and others are not contracting. And when they contract, that means they execute an agreement with them to make that construction. And any failures of UPDF can even be liable for legal redress because it's a contract. And he has even emphasized that for them they are not under a directive. Because where we are seeing UPDF constructing, there's some sort of directive to be given contract. So, Madam Chair, I never wanted to take long on this. Let us keep it for our report writing. How does it happen in different entities? The same entities, same regional referral hospitals, no hands off, eyes, even almost eyes are off, but these ones are given chance to contract
eyes
freely.
On, hands on, legs on.
Madam Chair, maybe what we could do is to get a contractual agreement between Jinja Regional Referral Hospital and UPDF.
You know, we are going to get there. So we take note of this delay. And you've said the project is complete. As we move ahead, you will educate us on how the process you go through to acquire services of UPDF.
Right. Open bidding, what?
So the other project is renovation of the main operating theatre. The contract, the commencement date was 14th October 24, expected completion 30th June. It was completed. This is there is no issue. This one is okay. So we got physical completion inspection, physical inspection of completed activities. We have this construction of the hospital. Well, this is the same. This is the fence, but the auditor notes. Let me see. The accounting officer explained that scheduled to meet the UPDF. What was wrong with this one? The auditor seemed to show that there are items that were incomplete.
Yeah, Madam
by the
Chair.
time of audit.
Madam Chair, the fencing project was batched with the drilling and motorization component, which by the time of audit, the auditors found that the water meter had not been installed, the transmission line was not in place, and the tank they were supposed to facelift had not been done. So this was what the auditor was raising, but our response is that we engaged the engineers brigade of UPDF regarding this matter of delays, and UPDF explained that the delay in their part was due to further consultations. They were making to come up with the best solution for the water tank, because the water tank was a very old one. They were weighing between a new one and the possibility of repair. However, this discussion was concluded and these works were eventually handed over and they're already in use.
Okay. But one would ask, had you paid UPDF 100%?
Madam Chair, you could allow me now explain why the issue of hands-on and hands-off is coming from by the nature of engagement we have. Now, the UPDF Engineers Brigade, following the Presidential Directive of 2021 and the guidance from PPDA, we are allowed to engage them. Now, the engagements which are done at the Ministry of Health level, like the oxygen plants and so on, they are projects overseen by Ministry of Health. But these particular projects we are talking about, they were our own. The resources were our own, and we directly engaged with UPDF. So what happens? We write to the PS, Minister of Defense and Veteran Affairs, saying that there is this work that needs to be done, and the Minister of the PS forwards that to the engineering brigade. They do their costing, and our engineers also do costing, and we compare notes. And once we agree on the costing, and then we sign a memorandum of understanding. And the way the brigade works is that you must transfer 100%, you front load. You pay 100% of the funds before they start work. So once we pay 100%, then they come and start the work. And how now we play our role is that we have site meetings with them.
Kindly.
And we monitor the works.
Madam Chair,
yes.
I'm requesting you kindly, don't dig deep into the UPDF issues. Because now, me, I was trying to save you. That's why I asked a simple question and ran away from that matter. Now you are bringing in PPDA, you are going to sail into deep waters. Kindly leave it as it is. For us, you have observed, you know, because now you are going back to what I was asking you. Directive, and what have you keep that? Doctor, you know, treat us very well, but the issue of UPDF and the contracts, leave it for the chair and the committee. Because I know what you were supposed to tell us, you had kept it. Now you was bringing it in slowly, but trying to insulate your answers so that you don't come to me again. But now you are trying to entice me to ask more questions. Let us go. No, I want us to keep it at what we got in Madam Chair and we move. I know why. Because you will set directives, how you are sending 100%. We know what is happening. And this committee is going to visit those areas. You are saying that they are now to completion. Room is there.
Honorable Song, the beauty with this kind of arrangement, it's not classified. It's open to audit, it's open to criticism. But for me...
Madam Chair, once you say it's open, and they never follow, the UPDF does not go through PPDA. That one is known, it's a common knowledge in this institution. And once he brings in the PPDA, he's going into other waters. But for us,
PPDA advised the issuing authority of the directive.
There are no guidelines.
But colleagues, for me, the only challenge that I see with, because I think the intention was to have works done in time, somehow cheaper, because the assumption was that the private sector is expensive, which wasn't the case. Because when you look through how you solicit for the services of UPDF and the bonanza of exemptions that you give them, the same treatment is not accorded to the private sector. You see? And, you know, just imagine somebody who does a business and for you have to front load, give them money 100%. Even they are at liberty to keep your money. They are not working, works are not yet done, they have your money. Even if they had fixed it somewhere, it would be making profit. So in some or the other, for me, I think there is some kind of injustice that is being done to some other sector. Number two, who check marks the other? Your engineer carries out an estimate. The engineering brigade does an estimate. They sit somewhere I will not say in a restaurant, but in an office, and agree on the prices, a meeting point. Now when they have grown a meeting point, this same engineer of yours is going to supervise the other one. So who check marks what the UPDF engineering brigade does?
Why I was even running, Madam, why I was running away, even if you ask them at what stage they get certificates of completion for every stage, oh, those are big questions.
They don't have.
UPDF, even if the project is worth 800 million and the hospital has 200 million, the directive will make them do what the money that is available.
For them, if they feel
but
that is
for
enough.
me, why I'm avoiding, and I don't want to put the doctor and their team into a lot of questions, because we know what we shall handle when we get them. The answer is a directive. Competency for the UPDF is another question. And completion of projects is another issue. The only thing we have learned from these ones, for them, they are paying directly from them, not from Ministry of Health. And those are questions for the other ministry when they come. Because these ones don't sit in the cabinet with the ministers, they are just regional referral. They are in Jinja, seeing traffic jam and all the railway lines there. But the real gist of how contracts are awarded to UPDF goes to the ministry when they come here. And then we look at those stalling projects when the money was paid to 100% and the works is not complete. This one cannot question a general for not finishing their work. Doctor, frankly speaking, can you go to Mbuyandi demand in a general, why aren't you finishing my project?
No, that's why when they give the money, for them they sit back and wait.
And wait until it is
when
done.
They come and work, and
then the
when
handover
they are tired,
function.
they will go.
They wait for the handover function.
So, We take note of the deficiencies with the engineering brigade, and colleagues, you should get concerned, because this thing has seriously this kind of directive stroke policy generated by a single individual. This has seriously affected the private sector. You've kicked them out unfairly, and we are enriching a certain category of people. Enriching a certain, and this is for us, we are here for accountability. It doesn't matter who takes the money, but you know, this money goes, you'll find that it goes to a single individual. But we can proceed. We have these after inspection, some of these sites were not operational. Construction of a hospital wall, fence and motorized, this was not utilized. Renovation of the main operating theater, this is being utilized, and the other is being, I think this is consequential. Delivery of services from key performance indicators. This analysis of admission and
because I was trying to look at maybe the accountant on the rehabilitation of the theaters. You see, earlier on we had been told the Good Samaritan that offered the 1 billion for the rehabilitation of the orthopedic construction. How have you reflected accountant in the books? Because I was trying to look for that figure. That donation.
Accountant, as you look at the donation, how did you capture it?
Show us where it is.
In the Board of Survey report, we reflected that building. It was not there before.
Not in the Board of Survey. I'm saying in the financials. In the financials.
That 1 billion.
How do you treat that donation?
When you get there, please tell us.
Doctor, when you check, but largest should be under committee. You check along a committee. You could see you are opening everywhere.
So as he checks, let's proceed. This is analysis of admissions. Doctor, you are going to speak to a few of these. We are looking at the number of admissions, number of deaths, and we are comparing the years 24 and 25. When you look at the number, most of these areas, the number of admissions have increased, and the number of deaths have also increased. But this emergency ward, 409 out of 9,000, don't you think this is much? Special care unit, 234 out of 1,000.
How big is your mortuary? Because
he talked about, didn't he explain the mortuary? These ones got an offer. They have a relationship with A+. So they have a very state-of-the-art mortuary in this country.
And the marketing value for the other company.
But corporate social responsibility.
I hope you have not constructed the churches and the mosques for what?
So
but
it is.
I have an issue on that.
What?
Establishment of services. We're having a relationship with hospitals. It is creating a competition for business on dead people. You know, I am serious on this, Madam Chair. I would do, when you go to Chirudu, all the funeral service companies have hired their own buildings outside. Then
we are coming close to where the customers.
Yeah, but now, if you establish a funeral service within the hospital, and you have a relationship to create a mortuary, that means whichever person dies, the contract, all bodies must go to one chairperson.
But do they have a contract
And
with
Madam Chair, let me drive this properly. I had that challenge one time. I don't want to mention one of the mission hospitals in Kampala. Somebody wanted to use the Uganda Funeral Services, but the body from the deathbed, already A+ had picked the body, and there was a battle between them and the others, people's wish. So one was stronger, took the body. Take keen interest, doctor. You should contract and say now you have served, because Uganda now has so many funeral services. And that would either spoil your name or the hospital's name. That one now, the deal is between A+ alone, or SAWUNGU plus alone, and nobody else. Yet, some of these people who lose their dear ones in those hospitals have their own interest in provision of funeral services. Day by day, funeral services are becoming cheaper and cheaper because many people have entered into that business. And it can be a disadvantage. I don't know, doctor, you could do. I don't want to spend much time on that, but be careful.
Yeah. Honorable Sawungu could be having, but you see, I wish you were here earlier when that matter came. Because our understanding was that first, when someone is taken or someone dies, I think there's a next of kin. The next of kin will have the right to the body, unless people want to bypass that. And two, once someone has died, I think it's now the relatives. The hospital does not force them, let A+ take it. A+ take it. I think this happened only because of getting services from near, and possibly others are looking for business. Once you are near there, it's easy for someone to get there other than ringing and say, come here. But because I've also seen A+ with Mengo Hospital. You see most of our cases we have had here, that's why they bring and take to Mengo, and then you pick from there if it's A+ handling. I think it's not unique to Jinja Regional Referral Hospital, but who comes in, you take caution over it. When you handle the way you handle, that must be a proper thing. But I think they're getting there because of maybe they want also to cut costs and partner with you such that they help you and do a good facility. Because I'm happy that for you now at least you have been able to have 18 what? 18 fridges. Fridge capacity. Unlike Soroti, which has 2, which even then, yeah. So even Kirudu. So I think that's it's just caution to avoid those cases where you end up tarnishing the name of the institution. But we have seen them do it elsewhere.
I thank you, Madam Chair. So don't say that SAWUNGU is in bad spirit of any company, because I contract all of them. A+ I'm with them, and we politicians, we are ever going for values and helping people. We have many clients, but just be arrive at that, because it is very important to know your contract, how it moves, to avoid challenges within. You remember one time there were people fighting in Chireka, I think Chirinya, where Uganda Funeral Services wanted to establish a funeral home, and the people in the village, Baganda and the other tribes here, we fear dead bodies, including me. The people revolted, say we shall not allow this funeral service here in our village. People are going to be crying every night and singing, and we shall not allow ghosts hovering in Chirinya every time. So, but I think in the spirit you put it, study it, and manage those who come in.
So, honorable colleagues, let us look at the delays. Jinja has many issues, So, and we still have Gulu, leader. Are they already here? The team is there. So, honorable colleagues, we have delivery of services from these key hospital performance activities, these indicators. Sorry? No, but he needs to, we need to really take note of these increments in deaths, in the number of deaths, much as you say the accident also increased. But so you can speak about.
Thank you, Madam Chair. On table 12, the number of indicators put there, let me speak to probably 3, the first 3. table 12, that's page 22. Oh,
It is, we on table 12. The issue is...
3.3, part D, yeah.
Continue
Part
from where
D.
you want.
So the issues of increased deaths in the emergency ward, pediatrics ward, number 3 is the maternity ward, those 3. If you see those 3, for example, they are associated with increased admissions. Generally speaking, keeping other factors constant, if you increase the admissions, then you are likely to see also more deaths. However, beyond that, these are areas where really a lot of blood is needed. We don't have a regional blood bank in Busoga. We always run into crisis of looking for blood because we get it from Nakasero. So this matter, we've been engaging different stakeholders on it. But Madam Chair, as I speak, KOICA, the South Korean government, has committed to undertake this construction of a regional blood bank. And we are at the advanced stages of having this project started. Actually, the Korean Red Cross has already been contracted. And very soon, we shall break ground and establish a regional blood bank. We think if we address this, then some of the avoidable deaths due to shortage of blood can be really handled. Thank you, Madam Chair.
Doctor, that would have been part of your challenges during your opening remarks. Because remember, the other time you appeared here, you had issues of the blood bank.
Yes.
Still, much as KOICA is intending to help you, it is still a challenge. Because as of now, you still have come to Nakasero to pick the blood, and you know how the traffic on that road could be. You have an aircraft, a watercraft. So,
Doctor, Madam, how long does the blood you get from the Nakasero blood bank take you after picking it from here to the hospital? How long do you spend? You know, Madam Chair, my son is a hemophilic, and I know what's meant by looking for blood and precipitate from Nakasero. He's an old man now.
You've become a scientist.
Yes, I learned a lot from Nakasero blood bank, but we could know because he's stocks for blood.
What does that mean?
Now, let me behave like a doctor, but a doctor can tell you. It's better than me at that.
You know, we've learned interacting with the
No, it's not
hospitals has made
confidential.
us learn so many things.
No,
Yeah.
the boy was born, if he plays and cuts himself, he bleeds non-stop. And the only way he can stop bleeding is by applying the precipitate, which is picked from blood. It's sort of like a mucus, which is transfused, and then
The blood stops.
It stops. But later on, we formed the Hemophilia Foundation of Uganda. We are getting the factors, because he's factor 9 deficient, and the others are factor 8 deficient. I think now I'm a real
That
doctor.
terminology now.
So, but now, for him, his is mild, but the others are severe. And without blood, a lot of death can occur. And it must be screened properly to get out that material. So that's why I was asking, Doctor, how do they stop?
Thank you for educating us in that area. I'll also educate you on neonates. I have a very good experience in those ones. So, Doctor?
Thank you, Madam Chair. So we have one blood collection unit based in the hospital. So it moves across Busoga to collect blood. The blood is not processed there, it's brought to Nakasero for processing. And then we place our orders. Now when we place orders, we don't get, in most cases, all of it, because what we are issued depends on what's available in the blood bank there at Nakasero. Yes, so we get what they are able to give us, depending on availability, and usually 2-3 days, it's done, we have to run back to ask for another one. So the consumption, especially in the pediatric ward and the maternity ward, is quite high, and we need a lot of it. That's why we think a sustainable solution will be having this regional blood bank that will have capacity to collect, process, and distribute within the region. Thank you.
Honorable colleagues, let's go to this table that shows, table 13, that shows the overall hospital performance. Doctor will take note of the increase in the numbers, but I've been so touched with this reduction in the numbers of normal delivery. 2023, 4,000. 24, 3,000. A difference of 1,200. You know, normally patients tell us because you doctors get money from C-section. Even if somebody comes when they can deliver normally, you tell them, no, it must be C-section. So, but even you should get concerned as medics, because naturally we must give birth the natural way. So is it a fashion that now you have to cut? Do patients just request for it, or you have terms and conditions? Because
we also hear you ladies, there are those who now prefer cesarean than having. So it's a two-way.
He's going to tell us. And doctors will respond. Honorable colleagues, when you go to 6, the number of C-sections have increased from 1,400 to 2,000, a difference of 556. What is causing this? What should we do? Is it because of the feeding? And doctor, you need to help us with this, because even with this increasing number of admissions, it's also not a good trend. Because save for the accidents, even the accidents, we must get a solution to the accidents. But whenever we improve on people who are sick, that means we have not done some part as a country. I was looking at, for example, causes of these sicknesses that have increased in the country. People have cancer, people have these others. Well, you know, I asked myself, what do I base on to form a menu of what I feed every day? Who helps me to really get that sensitization on how I should feed? For me, if I was the director, Regional Referral Hospital MULAGO, I would take on that, Ginger, I would take on that innovation to advise our community on how they should feed. It's up to the community to take it up, but you will have done your part. Because at times we fall sick not because we ought to have, you know, but because at times we do things out of ignorance. The way now we are being told exercising is important, but at times people don't know why they should feed the way they do. Let's pick that up. It is one nutrition what in science. Let's proceed. Yes, Honorable Sawungu.
The issue of these sick cases, cesarean, in Busoga, Doctor, you could help us. There was information of young girls being below the age of 12.
Teenage pregnancy.
Teenage pregnancies. Is this the cause? And what would be the remedy? Because it is common in Busoga, Eastern Uganda.
And you know, they normally tell us Basoga,
and then
Basoga very
we
strong.
hear some women, they even when they can afford the producing, they fear. They want to be cut. So could you help at the teenage issue? You would give us a better remedy if it is true, and how are you managing it? Because it must also move with you. You have outpatient programs on educating masses as you go for immunization and others. I think that's under your docket, doctor.
And we are told the Basoga women are strong. Why are they? It's a Kalamadima that are strong. No, these are fertile and strong. They do both. They tell you if you want really to have Busoga is endowed by nature, but the Magisu, most of them produce from home. And who gives the care? Doctor, proceed.
Thank you, Madam Chair. Madam Chair, I want to start with your point. It was a very interesting point. Many numbers good. So, you know, in statistics, my statistician is here. Sometimes we look at performance based on the numbers, but necessarily, many numbers are not necessarily always the best. Sometimes less is better, not so. So that speaks to the issue of prevention. Yes, health promotion and disease prevention is a core strategy of Ministry of Health now and government. We used to have what we call community health department with only 2 staff in the regional referral hospital. But in the new structure now, the community health department has been expanded. It's now called a public health department. It now has 19 staff in our structure. And we now have health professionals we would not have, like health educators, health inspectors, and so on, so which were not there. So right now, we are not only implementing treatment only, but we are engaging with the community through community dialogues, barazas, radio talk shows. In fact, our health educator has a whole program of radio engagement. Every week, yes, once a week, there's a radio talk show using RCC's program, but also our own resources. So we are trying to embark on this because the NCDs are on the rise, the non-communicable diseases, and we can only do more but through lifestyle changes and empowering the communities with the correct information. So, Madam Chair, we are on that journey, but the population is also growing.
And I also advise you on how you can do it.
Yes.
You know, you are aware, public servants, you are not good at gathering masses. We normally find you having engagements with 8 people. It's not easy to gather people. For me, I would advise you to take advantage of the structure at LC level, political leaders. You know what an LC does? They have every category of a leader, youth representative, women representative, those ones. If you can train those ones to help you cascade down, you'll be more effective because the structure is already existing. So please use some of those. We see you normally holding these meetings. People don't come. At times you don't have allowances. And when you don't have allowances, you will not get there. So make use of the existing political structures. We are talking about RDCs. We already have issues with RDCs. What meeting can RDCs hold? No, the radio program, their time. That is equally good, but also look at that lowest structure. You can...
Okay. Thank you, Madam Chair. We take note of that advice. There are existing structures we can ride on, indeed. We take that. Now, on the issue of the normal deliveries reducing and cesareans increasing, Madam Chair, as far as the referral hospitals are concerned, I'm not worried on that because really these normal deliveries should be handled by the lower level facilities. If we empower those facilities like we have been trying to do, they should be able to handle these normal deliveries. What comes to the regional referral, because the referral hospital should be complicated deliveries, which usually end up into operations, cesarean section. So it is for referral hospital, it's actually a fair picture to see more of the cesareans than the normal deliveries, which can be handled at Health Center 3 and the Health Center 4. So our public health department, together with the different departments, are working to strengthen the capacities of the lower level facilities so that they do their job.
But you know where your worry should be? Why do you have so many transfers? Because they come from the other lower units to come to you for C. What are the causes of some of these, increasing transfers? It should be an area of interest.
That's right, Madam Chair. And it is right, some members have mentioned the issue of teenage pregnancy. Indeed, in Busoga, we have a challenge of high teenage pregnancy, above the national average of 24%. And what we are doing with stakeholders, including the Busoga Kingdom, the Chabazinga team, is really to engage communities on addressing this challenge of girl child education and teenage pregnancy, how we can avoid it in general by collective actions of society. So we are working with different stakeholders to address that. But it is part of the contributions to the high cesarean section rates because many of these young girls cannot make it normally. Yeah.
Yes.
The Jinja regional referral has so many issues similar to what we have been handling. And tomorrow is Eid. But I don't know, with your guidance, if you could take us, there are some issues which have not been appearing in other hospitals.
Honorable Sawungu, when you look at the issue you are handling now, this is a very important issue. Actually, this is the reason, and it was not in any report.
Yes.
And honorable colleagues, we shall have a special gift to the auditor who handled Ginger.
Because
You'll find out the person was too detailed. No single auditor so far has given us this kind of figures. This information is very important, Honorable Sawungu, because these issues of the increase in cases that come from these district hospitals and health centers, that means something has not been done down there. These increases, why do we have so many C-sections? I mean, why do these referrals for C-sections? Why? Actually, this is the core of why this hospital should exist. So these things of maintenance of equipment, where we are going, that has been everywhere. You see? So I think, Doctor, this table is very important to inform decision making. Very important. Because when you look at even this number of outpatients, you know, the special outpatients, these are things technically we should look at for better planning.
with this table, I'm very okay.
Chair,
Madam
Chair,
Chair,
Chair, I think this is one take home for the liaison officer for Auditor General's office. Salongo, I hope we are picking. I think for regional reservoir officer, you should standardize because each hospital should have this type of table for us to compare. That's why the chairperson is giving credit to the auditors that did Ginger, because chairperson also, I think even Kawempe was a bit detailed.
Yeah,
Though he did not have a table, but he was also detailed. The auditors who did that. So there should be a standard presentation on key things, because it's not just about the financial accountability, but there is also this aspect here.
And
It informs policy. It informs the policy making.
The reason as why we give you money is to have a solution to these ones.
Madam Chair,
Yes,
I
Honorable.
also agree with you that this table forms the core of really why we are seated here. Many other things there are generic. They are cutting across. So if we explored this table, we can attend to ED. There's no problem. But let's look at this table in detail. Then the others are generic issues.
These
They are
drugs,
cutting across.
maintenance of equipment.
Are the ones I was referring to when I was bringing my seeking for your guidance.
Such that we
But
can
with
give
the table,
room.
I'm very okay.
So that we can give room to these ones who have come from far. They were here by 11. So
Then the traffic jam.
So, Doctor.
The feedback will be taken here.
Okay, please. Doctor, this is a very important table to you as an implementer. You know, we come here for purposes of continuous improvement in the interest of serving our people better. So with these increases, especially C-sections, much as you are a referral, but an increment with 1,200, it's on the higher side. We should get concerned. Why should women, you know, go for C? Why don't they have normal deliveries where they came from? Where is the problem? Those ones inform the future planning, you know. So, honorable colleagues, Salong has taken that up. We should have a standard when it goes to, you know, auditing of referral hospitals. We look at the core mandates of why these ones exist. We appreciate this absence of equipment, the inadequate maintenance. We do appreciate. But the core of medical, we should be having every list, where at the time you come here, a list of the core stuff that you have. You come here without core stuff in hospital, but because we are not given the details, we cannot, you know, ably make an informed decision on some of those. You see? So, honorable colleagues, we proceed. This maintenance of medical equipment, sir, it is consequential. These ones that are idle, very, very, when you look at the table, it's very alarming. These general outpatients, an increment by 100,000 from 57. These figures, what could be the reasons, Doctor?
For referrals to move.
Thank you, Chair. There are two aspects in this matter, especially for these referrals in. One of the issues that we have built better capacity. There are departments where we do not have specialists, like ENT, like dental, and then of course orthopedics and others. But we have made efforts in the recent years. All our departments have specialists now. We have also acquired equipment. So now the capacity, our capacity to handle specialist cases has improved. That's one aspect of it. The other aspect could be, which we need to explore, is there capacity in the lower level facilities, especially the general hospitals and the health center force, or they're just pushing everything to the regional referral? Because for us, we don't really want to take on everything. We want to take what really needs our attention. So it could be a capacity of the lower facilities that probably has a gap, but the fact that we have also built capacity in specialist areas is bringing in more clients to the hospital.
So, Doctor, then that should also have reflected on 13. On that, what you are saying should also reflect, because I'm seeing there the death has increased.
Of course, when they refer many.
But also if the facilities have improved and what, then there should have also been.
Yes.
Yeah, so maybe you explain the reason for this.
Yes. So
why the deaths are increased.
When the numbers you're handling increase, keeping other factors constant, then the deaths actually also increase. But for us now, that is a quality measure that yes, we have these deaths, we need to do something about it, because our mission should be really to bring down the deaths as minimal as possible. So we'll take that as a quality improvement initiative.
What do you mean by live births here on item 8?
Madam, that's the total number of newborns in that period. Maybe the SPN or my senior principal nursing officer is a specialist in MCH, can throw more light. Sister Lero.
Thank you very much. When you talk about live birth, we're looking at all women who came to the hospital and delivered.
Okay.
Yeah, because they can't deliver, but there are those who also die. I think somewhere there you've seen maternal death and newborn death. But every woman who delivers and is alive, the baby might be tired and dies later. They are all counted as live birth. It's from there where we calculate the maternal death rate and the newborn death rate. And that includes
I've not got it.
That includes women who
you
deliver.
Explain again.
Yeah. We look at all women who came to deliver. Yes. That includes those who delivered normally.
What is the difference between this one, and total number of deliveries?
Yeah, that one will include normal deliveries
And
plus the C-sections. Yeah.
Madam Chair,
yes
it would
or no?
make more sense if she indicated to us the number of live birth compared to the stillbirth. That is when it would actually be informative to us. But when you give the live birth alone, without us knowing what happened behind the curtains.
It's like this. We may not go into that, what happens behind the curtains. Like if all of us here went to Ginger Hospital, all the men and women, we went to deliver, and we all delivered. We have
Those are live births.
Yes, all the women have delivered, irrespective of how you delivered. Then the one who dies is the one they call the maternal death, the mother. Then the baby who dies is what they call a perinatal death.
Between the total number of deliveries, you say the total number of deliveries includes.
All of us went to deliver. So we are the total number of deliverers. All of us who went to deliver.
And what are the live
births?
births?
How you delivered. Yes, irrespective of how you delivered. Then you disaggregate. This one delivered by Caesar, this one delivered normally.
But all are birth.
So the women delivered, like all of us delivered. The way you deliver does not matter, but you delivered. Yeah.
The contrast of live birth is still birth.
But Madam,
right?
No, but no. I can deliver a stillbirth, and stillbirth also, if your baby breathes for 1 minute and dies.
What if they don't?
If they don't, that is either fresh birth, fresh stillbirth, but the skin has not peeled off. Meaning the baby died during the process of labor.
Madam Chair.
If you come when the baby has
Let her first explain.
You have got it.
So,
because, you see, why? Madam Chair.
Could be we are tired.
What I'm seeing, no, let me explain. I'm helping. The live birth is 5,184. When you go to cesarean, it is 2,000. You get it is less than the other one. When you go to maternal mortality, still the number goes low. But all these numbers filter within the live birth. Mathematics.
So you've just
this one.
There is no technicality, Honorable.
No, Madam Chair, it is this one.
Not true.
Me, I'm subtracting. It is just here.
So, honorable colleagues, we shall, let's just listen to one another. But the whole thing is we should pick interest in the table and use it, yes. Mubende, Honorable wanted to submit something?
No, Madam Chair, I think we can go by what she has told us, but it is not true. When you talk about the number of deliveries made, it includes the normal maternal birth and the C-section. Yes. But when you talk about live birth, on the contrary, you would talk about stillbirth. Isn't it, Accounting Officer?
Madam Chair.
Yes, we are talking about babies.
We have intrauterine death. Intrauterine death, and we also have the macerated stillbirth. I think that's what you are referring to. And those ones are not they are not born live. I think that's what you are alluding to. Yeah, so there is the total deliveries, which is everything. But then there's live births, which probably excludes the intrauterine deaths and the macerated stillbirths. Yeah, that's the difference.
But when the madam in charge explains, she confuses us. Because you cannot tell whether this birth we are talking about, the live birth we are talking about a live mother or a live baby. It is a little confusing when she explains. But I think the accounting officer has
already 4, to some minutes to 4 at the levels of... But we want to appreciate you for item 14, total number of maternal deaths. These have reduced by 21. Please go on reducing, because we would prefer having 0, if that can allow. Somebody saying it can't be, but I'm telling you, everyone, no mother would like to go to the labor suit and comes out with nothing. So, yeah, so for us, our preference is 0. For you, whether it is impossible, for us, our preference is 0. That is the standard.
Yeah.
That is our target.
But of course, Chairperson, you have seen, like on the note, this issue of shortage of blood. They may not have a direct control, but that's why we all need to push on both sides to ensure that blood is available. Like now they're talking about building the blood bank, I think, to give support. Give support. I'm happy that they are going to break ground. The one I think in Soroti now is, because I think it was handed over. It must be in cooperation. If this could be done in everywhere where there's a regional hospital, it would go a long way in helping the mothers.
And even honorable colleagues, when it comes to the maternal mortality ratio, they are also doing well.
But also
from 2 to 3 to a difference of 310 is a plus. You know, honorable colleagues, as we proceed, you don't know how it hurts to leave that word of the mothers who have given birth with somebody carried in a funny way. I mean, it is so hurting, eh? It is equivalent, now somebody has, when you lose a baby. So it is very tormenting, eh? No one would have loved to go through such a situation.
And even when they steal the baby.
Eh?
They are all terrible.
Stealing a baby is terrible.
Stealing a baby
and for
becomes
you,
even worse.
For you nurses, you know, when somebody goes through a C-section, even if it's normal birth, you are still in hospital, your colleagues have babies, for you don't have, you can become a witch. You know, it is very tormenting, that's the fact. Eh?
But also encouraging people to give
Madam
blood.
Chair.
Yes, Honorable.
We also why they had an increase in their referrals compared to the previous financial year. Referrals from them to the national.
Yeah, he can
referrals.
repeat for you, but he handled it. He had responded to that. Delayed collection of drugs. Next is these drug stockouts. We are going to take you by your response. The issue of blood, you've spoken to it. We are going to take you by your response. This UPDF Engineering Brigade, you've spoken about it. We have our conclusions on that. So
yes, this one they said it's waiting, which is not operational. but it's pending final testing by Green Label. Why are they not coming to test this Green Label? Or they have now come since that?
Madam Chair, that was by the time of audit, when the auditors interacted with us, that was the situation, because it was the incinerator was manned by Green Label, and when USAID withdrew funding from them abruptly, then they got stuck. But later we worked with them and we have sorted it, and we're now using that incinerator.
Yeah, but actually, Madam Chair, because I will not go back to that, and since we are, Madam Chair, the issue of incinerator, Dr. and the waste in your hospital,
the picture that you
incinerator not being functioning at any time it was is very bad. A hospital like yours with the waste, that query is on 3-1. Sincerely, this should not be appearing. A hospital must have an incinerator functioning all the time, because you must ban a lot of things, including those
lack of a comprehensive solid waste management plan.
Why, Doctor? And they are showing the garbage here.
And this is the same problem that you had the other time.
And Ginger was taken to be one of the cleanest hospitals by then. When I had come to this parliament, I remember. But now, you're going back. Incinerator is only used to burn all the you call them needles. Syringes, you what? And if it is not functioning, how can you explain that, Doctor? Professionally, really.
Thank you, Madam Chair.
As you respond to that, the impression that you gave us at the start is totally squashed by what we have gone through, dilapidated structures. But you can respond, and as we
So, Madam Chair, there was an arrangement by Minister of Health that contracted Green Label. There was funding coming through USAID to support regions manage medical waste. So what used to happen was that the medical waste we generate would be collected by Green Label and taken to a central incineration point in Iganga. So for the years I served there, that's what used to happen. However, when USAID, when Trump took office and his USAID funding was abruptly stopped, then Green Label was disabled. But fortunately, by the time this happened, Green Label had been contracted to construct a new incinerator for the hospital, but they had not handed over. So we are waiting for the handover. So when the funding from USAID was abruptly stopped, one, they could no longer collect our waste. Secondly, there were issues they still had to sort out with this incinerator. The tank was leaking. There were a few parts here and there they needed to fix. And they told us there was no money. But when we are caught up in that situation, then, of course, waste management became a problem. Waste started piling up in the hospital. And we said, no, this cannot happen. We must find a solution. So we worked with them, and we also utilized some hospital resources to make sure this tank was repaired. They handed over to us, and we are actually the ones now manning, because initially it was planned that they would run it with support from USAID, but now we are the ones running it. They have handed it over to us. So we fuel it, we maintain it, and it is functioning.
Honorable colleagues, Ginger has so many issues. However, we take note of these advances that you gave the engineering brigade. We take note of that. We shall see how to conclude. You told us your private wing was very okay, but the author notes the failure to provide services as stipulated in the private wing operation manual. You don't have enough staff. You don't have an operational theater. So, honorable colleagues, we are going to take them. For these others, we shall take you by your responses. These drug stockouts, we shall take you by failure to dispose of the old drugs.
On that 3.923, because in the private wing, we expected everything to be really perfect because there's money to it, and people will come there knowing these are the services. But you do realize that they only do obstetrics and gynecology. The others yet you are stipulated in your manual. General surgery, orthopedics, and orthopathology, ENT, ICU. Is it still the same case that only two? You only do obstetrics and gynecology? Those the private wing, you saying they're supposed to offer all of that.
Yes, Madam Chair, the private wing, our vision for it is to be a one-stop center to provide all the services. But we are still on a journey of making it work like that because there are certain components which are still not functioning, especially the surgical services where operations are needed and so on. That was not possible because the operating theater lacked equipment. But sorry? Yes, so the building, the private wing building has a provision for an operating theater. The space is there, but the equipment was not there. So what used to happen is that where surgery is required, we could not do it there. We could have to take the patient out of private wing and take to the public side and take to the main operating theater. But patients were not comfortable with that. When they come there in the private wing, they want to be served there, they want to go home from there. But as I speak now, we have found equipment. We have found equipment for the theater, and we are going to now do everything from within there.
Today, could you, if the chair allows, could you provide the information to this committee even after, to our clerk, through the chair, to know what are the standards of a private wing? Because this is an area where you are generating money from, for those. But now here, understaffed. Now, do you know what's happening, Madam Chair? These hospitals now, with the private wings, they're even developed where people can come and rest. Go to Nagarama. Very first-class private wing. And people go there if they have challenges, they rest and they pay money. Because that is for those who can afford. But when you see, I'm in a private wing, and even the staff are understaffed, what kind of private wing is that? Buildings? Could you help us, if the chair would accept, you give us that, we use it for others. We have met this problem in a number of regional referrals, and that could be one major NTR correction, most especially if people were in the cities.
No, Honorable, the beauty with this is the operating manual for private wings is a standard. So they handled it prematurely. You advanced yourselves to private section, yet you could not afford funding it. Because Honorable, he has the way he was introducing during his introductory remarks, he told you there is a serious improvement. So it was an improvement to this. So just imagine what used to happen before the improvement. So actually, that's why the other time we were told you close the private, do what you can afford. But the fact that you are advancing, people, it hurts to go for private, and you find services that are not commensurate to what you pay. What do you charge what are your charges for normal delivery and the C-section in the private wing?
Senior accountant, you remember that? I remember for cesarean sections, it's about 700,000, but normal. Can you remember what normal?
That can't be. It can't be 700. It can't be 700, I bet. C-section 700 in Ginger, private. Yeah.
I thought you charge me per day.
No, just those are theater fees. Leave alone the bed. The charges for the bed are different. For here, it is theater. Go to the theater, operate, come back. And
Chair, I want to provide some comfort for this House that Minister of Health, effective July 2025, has come up with a new guidance on private health services in this country. And that guidance is, we are now revising our manuals and aligning with that new guidance. And it gives guidance on even the fee structure based on the location, whether you're in the city, KCCA, or in our regional cities, or in the rural places. Now, prices are being determined based on that. So I think there's going to be, all right, I will be able to share it. I have it. I will share it to soft copy with the clerk.
Now that you have dilapidated staff structures, update us on your accommodation for staff. How many can you accommodate?
Chair, we have 109 housing units for Jinja Regional Referral Hospital, but we have 410 staff currently. So it means that we can only support a few staff. We accommodate those who are really critically needed to be around, but people like me and these administrators, most of us have to rent from elsewhere, from out.
Okay.
And it's one of our unfunded priorities. Actually, there is a storage staff house that we did, phase 1, which is accommodating, how many staff? 16 staff, 8 in the senior wing, 8 in the junior wing, and there was supposed to be phase B, which was supposed to also accommodate an equal number, but because of lack of development funding, we have not been able to do that. We need support in that area.
Honorable colleagues, we need to have our colleagues from LIDA. No, LIDA is coming. We want to see off the team from Jinja.
How do you treat it in the account? Did you find where you have placed it?
Have you found it?
How you treat it?
On page 8, we indicated that page 8 of the financial statement. In a summary form, because we are required to give a report on all the assets. So it's part of the assets. First of all, this asset was a donation to us. We did not receive any money in cash. Page 8. Yes, that's the first comment. We have been uploaded on the IFMS, so we have a register on the payment system that can be generated at any moment. It is part of it. And under the donations.
So the entry is, you know, that donation, I don't think it came through IFMIS, did it? It came from somewhere. So you would have indicated it somewhere, recognized somewhere. But if you say, oh, I've gone on IFMIS, then show us. You are creating trouble for yourself now.
Professionally, it's not there. It must be. Know how to treat it.
We treated it, however, we will commit in future to do a separate disclosure.
No.
Honorable colleagues, that is all for Jinja Regional Referral. I was looking at the report for implementation of the Treasury Memoranda. I'm not seeing it anywhere, but I want to thank you for appearing before the Public Accounts Committee of the 11th Parliament. We notice a slight improvement on paper because we've not gone physically to the hospital. But we take note of the issue of domestic arrears for water and electricity. Those are the utilities. And also take note of these other challenges: the dilapidated structures, the blood issue. Then we also have the machines, inadequate budget for maintenance. We've also looked at the inadequate budgeting, the staff understaffing. We've taken note of all these, but you make sure that with the little you have, you can at least deliver quality services. Do what you can. But you've told us that deliveries are for free. Actually, not deliveries alone, but you offer free medical services, save for the CT scan. And what else did you say? The private wing
services.
We shall go and spread the message to the people of Jinja that once you get charged of any fee, please report to police as long as you have evidence. So we want to thank you for serving your country. Just to remind you that professionally serve the people, because you can't be everywhere. You are in the line of medical, you will need a colleague in the line of legal. So what you give is what you will also be given. Others will reciprocate in the same way. So for me, my kind call is whenever you are given an opportunity to serve, give your best. Because in turn, you will also be served better when you go for other areas where you will need a service. We want to thank you, Journey Masses, as you get back to Jinja. It's still early, you can move. The fact that you have a lead car, you can Can also use an aircraft if you have, but we know they go through Namugongo. So we want to thank you. We wish you, Journey Masters, as you get back. For the Muslim colleagues, Eid Mubarak. I know it's tomorrow. Let's pray that the Almighty Allah rewards us abundantly, and also as we pray for our country, for really we can be better than this. Yeah, we shall push for a bigger, slightly bigger investment in this sector, because we are all candidates to hospitals. Any one of us can fall sick. Honorable colleagues, I want to thank you. The meeting is adjourned. Let's have a break of some 10 minutes as we come for Lira Regional Referral Hospital. The reason as to why we are handling hospitals is because, you know, the importance of hospitals. We want to see an improvement in the medical sector. That would be our contribution as the 11th Parliament. At least we want to ensure that we stand to be counted as having contributed to the increment in the budget for the sector of medical, especially on issues of understaffing, all of them across board. So I want to thank you, Journey Masters. Honorable Grania, see the team off, but you stop on the stairs of Parliament, then you let them go. We would have given you, now what will this be? Evening what? Will it be dinner? Wanted to give you something to eat, but we are failing to classify it. So the fact that we cannot classify what to give you, really, you have the water, please swiftly move out of Parliament and go back to Ginger. Greetings to the people of Ginger. Eid Mubarak. Meeting is adjourned.
Thank you so much, Madam Chair.
At the corner.